I saw that you wrote a blog on your website, the Fascia in Motion, and I loved how it compared. You have like you said fascia driven athletes versus muscle driven, and I'd love to kind of explore that a little bit more and kind of get your perspective on that.
Yeah, so this whole concept really helped me stem, and this brings us back to keeping strength and conditioning coaches in your circle. I've been extremely fortunate to sit with Bill Parisi and Seth Foreman, who are kind of two big time strength and conditioning coaches on the forefront of this fascial driven model. And if you don't know of the two of them, I highly recommend that you look into their work. But Bill is a big NFL strength and conditioning coach, and he's sort of taken on this whole fascial sling system or fascial training system where, we kind of know that muscles don't just work in isolation, but they work in integration. And what holds that integration together are these specific fascial slings or these lines that correlate together to create movement patterns, and then in sport, athletic movement patterns. And we see this all the time in individuals. The prime example that I'll use is Kevin Durant versus LeBron James. Kevin Durant is tall, skinny, long, lengthy, but is able to create separation in his sport almost better than anyone in terms of crossover moves, etc. And when he's in the post, he doesn't get moved. Same thing with Victor Wembanyama. People are like, well, this guy's too scrawny and too thin, and he's going to get bullied. And you watched him all year, and he's bullying others. It's, yeah, he's bigger, but he's lanky and long, but he's still so strong. He's just not hypertrophic. And that's just based on his build. He might be more ectomorphic. So I think understanding what type of athlete you have and what body composition you have plays a role in this.
Hey, Lewis, I just wanted to welcome you to the Wild Heart Athletics podcast, and I appreciate you sharing some time this morning to speak to us, and I'd love for you to kind of introduce yourself to our audience.
Yeah, Ben, thanks for having me. So I'm Lewis Lupowitz. I'm a physical therapist, board certified sports clinical specialist. It's weird for me to say after multiple attempts and finally getting it through, and a certified strength and conditioning specialist. Currently treating in Long Island out of Northwell Health, Orland and Cohen Orthopedic Group. We're an affiliate. So we are a private equity ortho group that's backed by the hospital system. So a lot of post-operative care, and youth through collegiate, through some professional athletic care. My primary focus is on shoulder, elbow, and knee rehab. But I do see, kind of everything being in the setting that I'm at. But, fortunate that I have great relationships with the physicians that I work with and the nearby high schools and collegiate teams. And I'm able to take care of the community that's raised me and served me throughout my sports career as well.
Awesome. Sounds like you guys are staying busy, especially with youth athletics and everything else.
Oh, fall is a very fun time for us, let me tell you.
I gotcha. So to kind of get the ball rolling, Lewis, I'm just really curious, how has being a physical therapist impacted your life? And did you ever think you would kind of go this route?
Yeah, my story into physical therapy is a funny one. So I never thought I would go this route I can't even tell you how young I was. I always said I was going to go into dentistry and, was on path for that and never really had this good reason why, other than I just kind of always said I was going to do it. But, living in college in a fraternity house with 50 friends, it's, you're the one medical student and it's like, what do I do? I got hurt, or I was dumb and got hurt. And what do I do? And I'm like, well, I'm studying all this science stuff and I don't really know how to take care of the people around me. So what am I doing going into dental? And it wasn't until my last week of undergraduate that I was like, yeah, I can't go this whole dental route. I've got to figure out something that can better serve my community or the people around me and study something that I'm a little bit more passionate about. So always played sports myself. Unfortunately, I didn't make it up to much higher level due to injuries myself. And I feel like, a few years back when I was playing sports, PT and athletic training wasn't as aware. So, I never went myself. I don't have that traditional story of got hurt, went to surgery, went to PT. It was cool and jumped in. It was like, no, never did this thing. Someone kind of recommended it. I went into a clinic, started working, and Was fortunate to be with a really good clinician that was seeing some really cool cases, a lot of athletes. And I was just like, cool, I think I can do this. And sure enough, took my missing credentials and jumped into PT school, and kind of the rest is history.
That's awesome. Yeah, it's kind of cool that you like don't have that original story. Like you have some people that like either they had like a grandparent and they saw a physical therapist, saw how they work with them, or like you said, you had injuries but you never went. And some people had injuries and went. I'm kind of like you. I just started a conversation with a physical therapist at a climbing gym, and he kind of got me to the dark side per se. And now I'm here, so it's really awesome. Um, I really like though, because you're talking about how you work with youth athletics and post surgery and stuff like that. And I know you're very fitness forward from looking at, your bio and stuff like that. Could you kind of talk about like the integration of like rehab and strength and conditioning and how that tailors to both post surgical people or pre surgery as well and youth athletics?
Yeah, I think if, especially in my setting where it's more sports oriented, I think really only difference between sports therapy and orthopedic therapy is that understanding of strength and conditioning principles and the ability to bridge that gap. So yeah, very fitness forward. I feel I wear sometimes too many hats in the clinic I'm at, where I'm their speed coach, performance coach, strength coach, PT, therapist. But what I think is extremely important is not only having a good understanding over your strength and conditioning principles, but having the ability to appreciate others with that same experience. So, in an insurance-based model where I'm at, there's times where I have individuals for a long-term care where I can be that strength and conditioning coach over the duration of their time frame. But there's other times where they're getting cut off, and I have to know of individuals in the surrounding area that I can trust and communicate with, to work with these athletes cohesively, where I can pass them off to a qualified strength and conditioning coach that'll see them 2 times a week. And then I'll see them once every other week to do more rehab specific or maybe make modifications to their programs as I see fit. But in that fitness forward model, I'm extremely keen on getting the ball rolling early, especially in a post-operative case, right? I mean, most of the post-operative cases I see are anywhere between a 6-month to an 18-month recovery, which is essentially a reset for an athlete. You're taking them from foundation through. There's really no other time in an athlete's career where they can kind of be like, okay, let's reset everything that I've kind of been doing, retrain these things, and build a stronger foundation. That way I can get back into sport and be better than I was prior. So if I have a lower extremity injury, I mean, we're doing upper extremity cardio conditioning once it's cleared by the physician. So I think that's how you can be what you deem as fitness forward, is understanding what can be trained in the rehab setting and then what needs to be more rehab specific in the rehab setting until once kind of those restrictions, precautions, et cetera, are lifted. And it really just becomes, medical training per se, but it's really strength and conditioning. So I think having a strong understanding is really what sets apart some of the better sports clinicians that I've seen or worked with over the years.
I gotcha. And you mentioned, you guys do like the upper extremity cardio if you like have a lower extremity patient. Could you kind of elaborate on like why you integrate that into it as far as, yeah.
Yeah. So I think one, especially when working with athletes, it's really hard to tell them, hey, you're doing nothing for 2 to 3 weeks to let your body heal. Because they think that they're going to, they already had a setback with the injury. Now it's like a mental component. So they're losing somewhat of their identity. They're not integrating with their team. They're not self-training. They're mainly a lot of the times motivated. And they don't understand that their body's actually probably burning more calories healing than it was working out. It's really hard to convince a youth athlete that. So, they want to get back working. So I try to just do as safe or, as appropriate of training as I can under their current guidelines, I guess. And I think what happens too often is in individuals that I work with, they get back to the field or they're cleared to start running, and then they go to run and they're so winded. They're just completely out of breath. And I'm like, so how'd it feel? And they're like, well, my knee or my shoulder or my this felt good, but I'm just so out of breath. I'm so out of shape. And it's like, in my first few years, I was like, why is that the case? What can we do better where an individual now is ready to run because they're fully ready to run from an all systems perspective, not just a musculoskeletal perspective, but from a cardiopulmonary perspective too. So I think getting that early integration is important to help them resave their identity, feel like they're working, and, progress them accordingly back to play.
Yeah, I love that. Like, like you said, the athletes that are out of breath, but it's like you're treating the person, not just the diagnosis they came in with, which I think, is going to help us in our profession win a whole lot more. And it sounds like it gives you a lot of wins as well in your career. What are kind of some benefits of like working with the youth athletes, just kind of staying on that front?
Yeah, I think there's benefits and flaws to it. It's not all, everyone's like, oh, I want to work with the youth athlete. It's great. It's fun. It's this, there's good and bad with everything. What's great is, yeah, it's an exciting case. They usually heal pretty well because they're young and they're healthy. They're a lot of the time motivated, but a lot of the time lack of understanding in terms of what to do, compliance issues. They don't drive themselves. So a lot of the time they're not on time, which is always a tough issue. So I think there's always good and bad. I enjoy it because I think you can get an individual and really shape their career. I mean, the amount of high school kids that I get that get then into collegiate careers and are, still keeping up with me while they're in their college setting, asking for advice, or even on spring break or fall break, just coming back in for checkups. I always say I don't like formally discharge anyone. I tell them that they're clear and they're allowed to be discharged, but if they want to keep coming in, they can. And I think what I've done well with the youth athlete that has allowed me to continue seeing them is I've sort of shaped a culture in the clinic I'm at where it's almost desirable to come to therapy and it's not burdensome. Um, you know, Individuals get annoyed when it's like, well, my insurance is cutting me off, or the doctor said I'm done, but I want to keep coming. Like, what should I do? Which, yeah, we're always trying to promote independence. But at the same time, I think if you can create a culture where, the individual is not dependent on you, but enjoys coming to you and is appreciative of your professional input on continued training progressions, then I think you've done almost a better job than just sending them on their way and being like, hey, you're free to fly. You want to maintain, I think, somewhat of a lifelong relationship with these individuals.
That's something I've noticed with like our profession too, is like like you said, the lifelong relationships. Like I've seen it at a clinic I worked at. People are constantly coming back. They're like referring their family and friends, which is great. You mentioned kind of like how insurance can cut off visits and stuff like that. So how do you kind of navigate that? And it sounds like you also have built networks with like strength and conditioning coaches that you can send like the athletes or even just the general population to.
Yeah. So that, I think that comes with time. I mean, even yesterday, I think is a prime example. I had an individual who I've seen in the past for an injury and came back to me after a surgery. They were at 3 weeks, but they had precautions through 6. Mainly the physician wanted them just getting their motion. I saw him, and within 5-10 minutes, I'm like, hey, you're going to get your motion and your insurance isn't great. And you know this from the last time around. I'll see you at 6 weeks. Let's take 3 weeks off, chill at home, follow this, and this, but we'll come back in 3 weeks when you need that supervision over real strengthening exercises, which is what you need more from a beneficial perspective. We'll get there. Or there's the flip side where it's like, hey, someone might feel stiff or may not get their motion, but I know that they're a motivated trainer. We'll front load those appointments. I'll give them a strength and conditioning perspective program, that they'll do independently on the tail end, or I'll get them in front of a strength and conditioning coach that I respect and trust and know will keep communication with me throughout their care, whether they're seeing me or not. So I think that just comes with time and understanding certain policies and, making mistakes and going through those flaws. The amount of times where I was like, all right, 3 months in, I lost the person and there's no shot I'm getting them back because the insurance just won't, versus some arguments that you can have and get more visits approved. But it comes with time and understanding policies. And it's the unfortunate reality that at least I live in now, in an insurance-based model. In an ideal world, we would never have to worry about that.
Yeah, it sounds like you have a very good like dynamic approach when it comes to like it just depends on the patient, right? Because you're meeting them where they're at and with the insurance and things. So can you kind of speak to the benefits of like our profession now starting to get more direct access and like how that's really benefits the population as a whole as well?
Yeah, I think it just saves time. I mean, how many times does someone who got injured acutely have to first go to a physician, get an X-ray, potentially get an MRI approval, then go to PT? It's like that's 2 weeks to potentially get an appointment, a week and a half to see the to like get the results. You know what I mean? And then by the time they're in rehab, it's like 3-4 weeks after the fact, and it's like, now this went from an acute issue to a subacute and closer to chronic issue. It's like, if you just get in, we'll see us, we'll get you jump started, and then, get the appointment with us and then get the referral from your MD, I don't think you have to just always wait, especially if you have direct access. Get those 1 or 2 visits because you'll probably get in with us a little bit sooner than the physician, and then get the physician referral where it doesn't have to be direct access anymore. I know it's state to state dependent. In my case, it's 10 visits or 30 days care. So a lot of the time I'll need that follow-up referral anyway. But if they can start with me, then I think it's just an easier process overall.
Yeah, I think the state dependent thing kind of can put a niche in it or some hurdles into it. But what I think is really cool, like you said, they can get in with us and get a whole lot faster. And instead of something becoming, subacute to chronic, so it's long term, they get in and see us quickly. And like that's not to say the doctors aren't needed, right? We're not going to talk bad about other healthcare professions. It's just sometimes our area of expertise are a little bit different than theirs, which is really phenomenal. Which gives you that holistic healthcare approach. Could you speak though to like, you have those patients that, let's say, chronic back pain patient, what's kind of the benefits of them coming to see us kind of out the gate instead of going directly to their doctor now that we're coming more direct access?
Yeah. So I think, especially in those instances, we know that the literature is so mixed in that population that, some people in that chronic state may truly need to see pain management and get a physician on board. They may respond to generalized exercise. They may respond to movement specific based exercise. They may respond to just rest or lifestyle modifications. But I think getting them in front of a healthcare professional as soon as possible to assist with this and getting, a couple different perspectives on what could be the root cause of the issue is always beneficial. And I think you have to work in a collaborative approach. I'm fortunate in the setting where my physicians are right next door. I mean, there's not a day that goes by that I don't have a conversation with a physician for a patient who I'm treating. And that's just the fortunate um, environment that I'm in, and was kind of the reason that I chose to be in the setting that I work in currently, was to have that relationship so close by. I mean, it could be a pain if you're in an outstanding clinic. By the time that you finally get in touch with a physician or their PA or athletic trainer, appointment's over. Whereas I could just be like, hey, give me 1 second. Let me just go get a second opinion on that. And I round the bend, talk to the doc, come right back, which is nice. So I think, yeah, in a chronic case, it's just important that that individual seek the opinion that's best suited for them.
Yeah, I appreciate your insight on that. And you mentioned what I think something we should talk about too is like lifestyle factors, right? And I think society is becoming more and more aware of like how lifestyle factors are impacting like their overall health, how it can impact their pain and things like that. So would you mind kind of speaking on that front?
Yeah, definitely. I think, I work with the scholastic athlete a lot of the time. So I'll give them multiple home programs. One is, hey, this is what you're doing at home. This is what you're doing in the gym. And this is what you're doing in school. The amount of times, like if I have an ACL, that I'm telling them, hey, you're sliding a second chair up, putting your backpack on your leg to low load. And we're just every 10 minutes in class. You have 9 periods a day, 8 periods a day. If you can get 10 minutes every period, there's no reason why you should be lacking extension. In the other 10 minutes, I know you're, for the most part, not always paying attention. You're doing quad sets during that class. There's no reason why you can't do quad sets or little straight leg raises from there. Um, Same thing with shoulders, just simple circles in your chair. But anything that they can do throughout the day, we know that more and more people are sedentary or seated, and this more forward posture. So that also translates to what I do in the clinic. I mean, very rarely do I have individuals ride the bike anymore. They only ride the bike more for a motion perspective versus a cardio perspective, but I want them up, standing, moving, not necessarily just sitting and exercising when they've been sitting for the majority of their day.
Could you elaborate on the benefits of movement? Because you keep throwing that word out there, and I think people out there might want to, maybe they don't understand like how important that movement is.
Yeah. So, um, the way that I'll structure a program when someone comes into me is I usually get them on the table first, more just to see where they're at from a mental perspective. We talk about these lifestyle things. So I may have a plan written up for what I want to do, but an athlete may have had a stressful day or something went wrong at school or this with their friends or blah, 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 blah. And, we have to modify based on where their headspace is. Or I can potentially break through where they're at when they come in and try to get them into more of like this, okay, we're going to get better today type headspace. And then from there, what I mean by movement is some sort of cardio to try and generate blood flow, generalized blood flow into the area that we're treating. And then more dynamic movements. So some sort of stretch pattern or flow like pattern. Then we work into some isometrics to try and work on tendons or restoration of healing of tendons, because a lot of the time that's what I'm working on is ligamentous issues. And then from there, I work into my more power-based training than strength-based training. So power would be, faster movements, 3 sets, 4 to 6. Strength would be 3 sets, 6 to 8, higher load, and then hypertrophy. Whether that includes or doesn't include blood flow restriction will vary on the individual, but hypertrophy could be anything of more single leg exercises, 3 sets of 12, 15, upwards of 20, even towards failure. And then we'll work into some dynamic single leg balance activities. But that's my generalized flow and what I mean by movement. I think at least the population that I treat is more athletic base and looking to get back into sport, where they're not going to be doing things such as just self-care ADLs or performance ADLs. And I think, a lot of the times people come in and I'm like, what do you do for exercise? And they say, well, I walk. And don't get me wrong, walking is unbelievable, but walking is not exercise. That's a requirement of life. I think you have to be able to do that. And yeah, if you're walking miles on end, yes, that is exercise. But if you can add in some stretches along the way and just different, transverse plane, frontal plane, other planes of motion, I think that's more beneficial than just straight line walking.
Yeah, I think that's true, right? Everybody gets stuck on like okay, well, I walk a couple miles a day. It's like that's really great. I don't want to change that up, but we need to talk about maybe adding, like you said, some strength training in there, some power strength, and then also on different planes instead of just going forward and backward. Let's go side to side or maybe diagonal, just because those are going to help increase your quality of life, which is what we're here to do. Because some of these people, if they don't, and granted, you work with athletic population, so that's obviously very good for them, but this also applies to geriatric patients and things like that, which we're starting to see get more, I would say, into the strength and conditioning or like the fitness forward rehab space, which is great to see.
Yeah. And I think, again, what's nice is obviously in my clinic, we see all lifespan, but when you have an elder individual watching a youth individual train, they get a little bit more motivated to be like, I don't want to just be on the table doing this. They almost get like this youthfulness to them and they want to do more. And doesn't mean that they have to be doing like crazy, sprints or change of direction things, but why can't they do more squats or even like a med ball slam or something where they're increasing speed or even a throw of sorts? I think slams and throws are great for the elder individuals. It's, power training, which is usually lost, elasticity training, which is usually lost, and balance once they finally hold and release something, which is what we're always training anyway. So it doesn't just have to be stand in parallel bars on a foam and try to hold on for dear life. I don't know how much carryover that would have versus, combining elements of strength and conditioning with those balance-based principles that we're trying to hit on.
Yeah, I think that's just what's so unique about our profession is just like it's like a big playground, and like we can meet people where they're at, and it's like, well, what are your goals? And then from there, that's where we kind of back plan. And I think that's where a lot of people like to see us, and they're starting to see benefits of our profession.
Definitely.
Kind of sticking with motion, I saw that you wrote a blog on your website, the Fascia in Motion, and I loved how it compared. You have like you said fascia driven athletes versus muscle driven, and I'd love to kind of explore that a little bit more and kind of get your perspective on that.
Yeah, so this whole concept really helped me stem, and this brings us back to keeping strength and conditioning coaches in your circle. I've been extremely fortunate to sit with Bill Parisi and Seth Foreman, who are kind of two big time strength and conditioning coaches on the forefront of this fascial driven model. And if you don't know of the two of them, I highly recommend that you look into their work. But Bill is a big NFL strength and conditioning coach, and he's sort of taken on this whole fascial sling system or fascial training system where, we kind of know that muscles don't just work in isolation, but they work in integration. And what holds that integration together are these specific fascial slings or these lines that correlate together to create movement patterns, and then in sport athletic movement patterns. And we see this all the time in individuals. The prime example that I'll use is Kevin Durant versus LeBron James. Kevin Durant is tall, skinny, long, lengthy, but is able to create separation in his sport almost better than anyone in terms of crossover moves, etc. And when he's in the post, he doesn't get moved. Same thing with Victor Wembanyama. People are like, well, this guy's too scrawny and too thin, and he's going to get bullied. And you watched him all year, and he's bullying others. It's, yeah, he's bigger, but he's lanky and long, but he's still so strong. He's just not hypertrophic. And that's just based on his build. He might be more ectomorphic. So I think understanding what type of athlete you have and what body composition you have plays a role in this as well. LeBron James is more hypertrophic. Yes, he's still fascial driven because his body works so fluidly, but he just has the ability based on his composition to build more muscle tissue. So I think you have to train both. Which is bringing us back to this movement. I think earlier in rehab, I do a lot more isolation based exercises because there is a deficient tissue that needs to be targeted and trained. And then as we work further, we have to work back in movement patterns and specific movement principles, which is more of like this fascial driven model where it's specific patterns, specific training movements that allow individuals to get back into running, cutting, change of direction. And then for your elder individual, even just like your squatting and lunging patterns, where something I use a lot of the time are like these 3D straps, where even if someone is doing a sagittal based squat, they have a 3D or a transverse plane resistance that's training their fascial system to stabilize. So from there, then we can work and layer in where, okay, now that we've worked sagittal with transverse resistance, let's work transverse with transverse resistance along that continuum to really get back into what it is that we do, which is really rotate in sport.
Could you speak on like how you put those, whether it be athlete or like the general population, into either the fascia driven or the muscle driven?
Yeah, that's a good question as well. And I think that'll always depend on, specificity demands. What is it that their goal is? What is it that they're returning to? I think everyone needs some sort of fascial driven model because of just movement patterning. But if it's an elder individual who's not necessarily getting back to higher end demands, they're more just getting back to like self care activities, we may not be as resistive or as explosive in that, but we'll still train those patterns more in a slower speed. But I mean, even if you're just picking something up off the ground, you're turning and lifting. It's usually no one really squares up and lifts. As much as we try to teach people, hey, keep the laundry basket between your legs, squat down perfectly and lift it up. It's like, no, I'm probably just going to go over there and grab it because it's there and I'm going to grab it. So I think if we can integrate that into what we do in the clinic, or at least add resistance that emulates what it is that we're going to do in the real world, we can better bridge that gap from what it is that we're doing in our, playground per se, and what it is that we're going to do in the real world application.
Yeah, I like how you brought up the fact, like, no one's going to come down and do like a perfect squat deadlift to pick up a box, right? They're going to just kind of grab it and go. And I think that it's a good segue into speaking of how we integrate movements for people where they're at so that their body is used to that stimulus so that they don't per se throw out their back.
Yeah, no, I totally agree. I think part of that comes from like your evaluation, part of that comes from your understanding of the individual, and part of that comes from what stimulus you provide to that individual to bridge that gap. You know, if you have someone that, you know, truly may be, you know, we'll call it type A, more focused, they might actually listen and actually keep things in line if their back is hurting them. But again, you want to break that mold and make it just normal life. You know, the last thing I want is for an individual to be thinking about what their injury is. That's the first thing that I try to break is that kinesiophobic thought process. Because I think if it's something that's in the back of their mind, then, you know, I talked about how I like having individuals come back to me, but only for the reason that they enjoy it and want to feel better, not for the reason that they still feel like they need to and feel fearful of what it is that's going on.
Yeah, I think that's a perfect distinction, right? Coming back because they enjoyed it and they liked it versus, you know, that fear of pain or fear of their injury and things like that, which a lot of people, you know, and myself included, it's like that fear driven. Because what I'm starting to learn is that pain doesn't necessarily mean, you know, the quality of tissue health, which is a new concept to me, which I am really diving into, which I love.
Oh yeah. Oh yeah. And that's that can definitely be a hard thing to indicate to especially my population too, which is more youth athlete. They don't really understand that concept of pain. You know, a lot of the kids I see, they have no training stimulus other than sport. And sport is a wonderful stimulus. It is the stimulus for these athletes, but there needs to be what I try to explain to them is pain sometimes is this alarm that's going off where your body is basically telling you, hey, you're doing a lot of this, but I may not have the capacity to handle all of that just for a little bit of time. So what do? We try to train and bridge that gap. You know, here's what you want to do, here's what your body will allow you to do, and if we do more of this, we get closer to this. And I, you know, I then working with younger kids, I try to use that red light, green light system where pain is a real thing. Let's listen to it, but let's understand that we can train through it. You know, I don't enjoy when I see someone being like, doing, let's say, an exercise and they just go, oh, I have pain. And they expect that the clinician's going to say, oh, don't worry, you could stop. We'll just change it or we'll hold off today. No, we'll modify load or we'll modify range of motion, but we're still going to do this movement because it's what I think is most needed for that tissue specifically. And in that case, to me, sometimes pain is beneficial as a trigger. If I hear pain, it might mean, okay, I'm specifically targeting the stimulus that their body is telling them they can't quite handle. So, how can I manipulate that so it's at least more tolerable in the time being to then allow them to have less pain and train towards what it is deficient versus just eliminate it entirely.
Yeah, and I think that's the game, right? You know, is finding that balance of like the right amount of pain threshold that the patient can tolerate versus because you know a youth athlete's going to tolerate more than maybe your geriatric patient, and then everybody's got their own different pain tolerance. And I like that you brought in the fact that it's like, no, we can modify things to do it, but we've got to meet that threshold to make that, you know, whether it be muscle, tendon, whatever's going on, stronger. And I think that's something that we as physical therapists or you as physical therapists is capable of explaining to a patient through that patient education.
That's the art of it. It is a science, but it is an art, and I think that's the art of it too. Is being able to communicate that, address that there's a goal in mind as to why we're working through this, and explaining that it is okay and why it's okay to what extent as well.
Yeah, I think that's a perfect explanation that, you know, it is okay, you know, to have that pain during this, but at the same time, you'll notice over time that pain is going to dwindle.
Mm-hmm.
And kind of going into the understanding and patient education, I noticed that you spent some time with Kevin Wilkes and that he's really big into like neurocognitive training along with like the strength and conditioning. And we've kind of hit on, you know, the strength and conditioning side. So I'd love for you to speak on like the neurocognitive side and kind of the benefits of that and maybe combining that for both populations, whether it be athletics or,
Yeah.
you know, geriatrics.
Yeah, and Kevin's been a huge inspiration in my career, and I wouldn't be where I'm at without his guidance and continued mentorship, and was really fortunate to have that experience. So, I'm perpetually indebted and always thank him for that. And I think what we've really learned over the years is I think any injury is a neural injury. Yes, we're musculoskeletal experts, at least in my setting, but I also am treating a neurologic injury. And Dustin Grooms, Meredith Chaput have been doing amazing work in their respective cohorts on this topic. And we're really getting a better understanding that any injury does affect the brain. But what we're learning now is what areas of the brain are being affected, and what does that mean in terms of our return. And this varies based on body part, it varies based on injury, it varies based on a lot of things. But what we're starting to, at least from a generalized perspective, understand is that there's a increased, at least from a lower body perspective, there's an increased visual component that's required early on after an injury. And there's an inherent loss in proprioception due to an increase requirement on visual demand. So sometimes early on, you want to allow for that visual component to break through your muscle inhibition, but then you want to start to remove it to allow things to become more automatic. And I hope that makes sense. And they do a better job of explaining it than I do. But for a simple perspective, what I like doing, let's say early on, I have an ACL. And instead of telling them to just use a Russian stim and, make a quad. Okay, yeah, we put that thing pretty high up and they made their quad muscle. Great. Now turn it off. What happens? Well, they can't make their quad muscle. So what do? Well, of course, turn up the stimulus. Let's make it higher, right? Let's turn that thing up even higher and they'll definitely make their quad. Well, no, that's not quite what's going on. So early on, I like using biofeedback or some sort of visual component, whether it be like a laser or some sort of target that they can aim towards, or a heel pop or some sort of visual cue where they can see what needs to be done to do the task that it is that I want them to do. Once they're able to do that task, so now let's say they can make an adequate quad set and they can start to do a straight leg raise without a lag. And the amount of times that you see someone just like staring at their leg to do a straight leg raise, like, dear God, let me hold on to this before I drop it. That's where you can start to come in and try to make things more automatic, where I'll jump in on a kid and be like, hey, cool, you're doing a straight leg raise and you're really focused on that and it looks amazing. Now start counting backwards from 100 by sevens. And now they have to think about math versus think about their knee. So we're not only training the neurocognitive component, but we're also breaking this kinesiophobic perspective where, okay, yeah, now I can just move my leg and I don't have to think about it, which then will translate into standing, walking, squatting, where I don't have to think about my knee. I just think about the task at hand. So, then eventually when they're doing their mini squats, I may put like blaze pod lights on the table or reactive lights, and red, yellow, green. If it's red, you freeze. If it's green, you keep doing squats. If it's yellow, you slow down the squat pattern. Or right hand red, left hand blue. But as you're doing your mini squats, you're just tapping these lights. Because again, I want them to focus on lights, not focus on knee. Break this mold that's going on. But again, a lot of their work has helped me understand this through time, and it comes into practice as well. It takes time to learn how to integrate that too early on. But I think a lot of the times we only see like the later phases of these lights where it's like cool cutting training or jump training or this, but getting this integrated really early into their care and then having an understanding of the beneficial component later in care, where now down the road, if we're doing hop testing, the amount of times that I've done a hop test with a kid and then they come back like 2 weeks later after failing and they're like, can we try that again? I've been practicing. Great. Now they've been standing in their kitchen, probably doing single leg hops all day just in hopes of passing a test so they can return to sport. So now we make these tests a little bit more reactive, where they may jump in the air and we call out a specific landing leg. To me, that's way more demanding than what sport will have. And we know that sport is constant decision making. So there has to be a cognitive component to the testing versus stand and jump and land. It could be stand and jump, and now what leg do you land on? Or if there's lights in front of you, what was the sequence of the lights that occurred during your jump and land process? Because there's always multiple factors going on. And this will be further explained in a nice commentary that myself, Kevin, Zach Thomas, and Morgan, who's Kevin's current fellow, put out, and it should be in an upcoming issue of IJSPT shortly, but it should be. So we'll have further on that. But most of the work I got to attribute to Dustin Groom's Meredith Chaput, and obviously I think just Kevin's brain in the clinic. When we first got these Blaze pods, it was like, whoa, okay, this is, we didn't really get it at first, and then we were toying around with it, and now it's like a day doesn't go by that we don't integrate it. And then, youth athletes are more motivated by it because it becomes competition. There's a score, there's a reaction component. We put up a board in the clinic with who has the high score. So they come back in and they're trying to beat their score or their colleague's score or another patient's score. And, but you have to understand what you're doing from a true neural perspective on top of that.
Yeah, I think that's what's very fascinating about this, right? Is like that neurocognitive part where they have to think, and then it's kind of like you're taking them, as a weird way to explain it, out of their body so that their body can automatically do what it needs to do to make sure it's safe. But then you're making their mind work because, like you said, in sports and in life, you're always constantly thinking and having to think and not be aware of your body. So I really love this approach. And is there a time and place for it, or could you start it as early as possible?
Yeah, I try to start it as early as possible. Day one. I mean, it really depends. And Meredith's put out a really good paper, a clinical commentary, or in JOSPT in the 2024 JOSPT. I forget what month, but it was based on this control to chaos continuum model that she then put towards neurocognitive approach in ACL from early to late stage. And it could be as soon as within day one this progression happens, or over the course of a week, but there are certain markers that you want to hit as you go along that time frame. And it will always depend on the individual as far as like what neural principles are they deficient in and what do they need to work on more so versus another.
Awesome. I appreciate all your insight into that, because to me, I just kind of started looking at Kevin Wilkes stuff on Instagram, and I was like, this is very interesting. I can't wait to kind of explore this too once I'm, out of the program and stuff like that, because it just seems very interesting. And then the way you explain it, it's so simple. It's like, oh, that makes total sense.
Yeah, and I think Instagram is great, but it can have its flaws where, people see, Kevin doing, perturbations or all this stuff, and they're like, well, that's circusy and that's hocus pocusy. But if you're there and you understand and you ask questions, there's always a rationale behind what's being done. And from a surface perspective and a visual Instagram 30-second perspective, you don't always have that understanding of what is the intention behind it. And another person that goes under scrutiny too is Dr. Reef down in Miami, where he's doing stuff with athletes. And, maybe it's one video of them balancing and catching something and this and that. And it's just one glimpse of what their training process is. Do you really think professional athletes would go to these individuals if that's all that they did and they didn't get back to play? I mean, there's so much more that's going on, and a reason that their reputation exceeds themselves. This is just one instance, one clip of what's going on in the clinic. And it shows, again, back to this culture point, it's a fun environment to actually rehab and get better. It's not all just, hey, this is what we're doing today. It makes for an environment that people want to come back to, and actually enjoy being in.
Again, I think that just speaks to like the dynamic of our profession, and just honestly, I feel very honored to one day be a part of it. And just, I can see the wheels spinning already, like, of everything. It's incredible.
Yeah, and it's great that we have younger clinicians like yourself who are motivated and doing things like this to reach out to other clinicians, not just myself, but a million, to try and just communicate. It's a really small world. It seems so big, but it really is so tight knit. And not only from like a global perspective, but then once you start to specialize within that niche, I mean, it is way smaller than you think. And it's just cool to be able to reach out to people that seem so big within the profession, but are always so open arms. And, having worked with Kevin, I've been extremely fortunate to be able to build relationships with other clinicians that he's had over the years. Rob Mansk, who is former AASPT president, Mike Reinold, Lenny Macrina, George Davies, Tim Tyler, Ashley Campbell. I mean, these are people that in school you like read about their work, and now it's like I could text any of them at any point in the day and just hop on a call if I have a conversation about it or have a question about a clinic, like a patient. And it's like, that's a small world, and you wouldn't think that would be the case. But it is. And if you just keep putting yourself out there and building connections and relationships and seeking interest and asking the right questions, then it's a lot easier done, a lot easier to do.
Yeah, I think the culture is like the big thing. And then, you mentioned mentorship because you've had your own, and I noticed that like I saw that you published a couple articles. You just mentioned that you worked on one with Kevin Wilkes and some of the others. And then I also noticed that in your bio it said you published a textbook, or I guess maybe helped in a textbook. And so can you speak to the fact of like mentorship and its benefits, both for the person being mentored and then being the person that mentors someone else?
Yeah, and I think this question gets brought up all the time of like, how do you get mentorship, right? And
Yeah.
I think the biggest thing that you have to understand is like, it's a time consuming thing for the mentor to take on a mentee. So what is it that you're doing as a potential mentee that would be from the perspective of the mentor, like, hey, yeah, I actually do want to set aside time in my life to do this. And I think I've taken on students every now and again, and but it's an interview process if you want to do a clinical rotation. Why? Because I want to see that you've done research on who it is that you're learning from, you have similar values, and that I'm willing to take time out of what it is that I'm doing to invest in your growth and your development versus, hey, yeah, I saw you on Instagram and you do some cool exercises and I'd like to learn more about that. Like, no, someone like yourself who's like, I went through your website. I saw that you wrote about this. I have questions about that. You've written an article or a textbook on that, and I want to learn more about your style of treatment. To me, that would be someone that I'm more willing to take time out of my life and put an investment in and be like, hey, this person came with qualified questions. They already did their background check. They have um, a truer meaning behind what it is that they want to learn versus I saw this and I like that and I want to do that. Teach me. It's not a spoon-fed thing. It's it's a growing process from both ends. And anyone that I want to mentor, I also want to learn from as well. Because like you say, we're always getting different perspectives from other clinicians around us. And it's all about that underlying intention. So if you can now grow and gain more from someone else, I think that's so beneficial. And Kevin's taken on a fellow for, I don't want to say how many years, and he won't want me to say how many years, but it's been nonstop throughout his career. And he's built this network of individuals under his sort of like tree. It's kind of like a coaching tree in the NFL, but I'm fortunate to be a part of that tree and hope to expand it even further based on what I've been taught. And going back to the fact that I can text any of these, we'll call them master clinicians, they're always seeking to mentor further and teach further, and they do something in education. So that's something that I've devoted myself to want to do throughout my career as well, is always give back to the profession, because I've been so fortunate to receive that as well. But you have to, if you're seeking it, understand that it's not just going to be given to you. And during the process, there'll be days where it's more given to you versus less given to you. Life is a factor. There may be good days and bad days, and better days to ask questions and worse days to ask questions. So, you're with this person for a long time. Read their schedule, read their life, and get a better understanding of how to integrate yourself as a mentee to them. Don't just expect it to always be given to you all the time.
Yeah, no, I think you explained that very perfectly. I think that's somewhere people like the mentee don't understand, or maybe they just don't think about it because maybe they haven't been a mentor before. But like you said, it is a time commitment. And yeah, it's a time commitment on the mentee, but also the mentor. And then something that really stuck out to me too is, like you said, you're both learning from each other, and I think that's the big thing too. like you said, coming prepared with questions or ideas and have done your research is going to help, both of you guys learn from each other and make that more of a greater relationship.
100%. 100%.
Well, Lewis, I really do appreciate your time today and coming on and talking to me. We've hit so many fantastic topics, and I'm sure people can learn a lot from us. And I take it people can still follow you on your Instagram, and are there other places to find you or any information?
Yeah, as of now, it's just really main thing is Instagram, Lewis_Lupowitz_DPT. I use LinkedIn, but am more active on Instagram, and have a website, lewislupowitzDPT.com, if you want to learn any more about like those blogs that you mentioned, or articles or textbooks, etc.
Awesome. Again, I really appreciate your time this morning.
Yeah, my pleasure. Thanks for having me.